today there are 5 interesting cases from the Department of Internal Medicine, Lisie Hospital. So, to moderate this, I invite Dr. Jilse George and Dr. Abhilish Chacko to conduct the meeting. Over to you, Dr. Jilse.
Good evening to one and all. Without further delay, we'll go into the topic proper. So today we have 5 interesting cases. The particularity of these cases are difficult, challenging, and not seen on a regular day-to-day basis. So with a further delay, we'll start with the topics. I invite Dr. Thasmi to begin with the first topic. Thasmi is a second-year DNB resident.
Good evening, Manano.
Yeah, over to Dr. Thasmi.
Good evening, Manano. Big things come in small packages. My case is Mrs. A, 64-year-old female, housewife, coming from Matipura. Presenting complaints, fever 4 weeks, dysuria 1 week. Patient was apparently normal 4 weeks back. Her complaint started as low-grade intermittent fever, acute onset, no diurnal variation. It was associated with dysuria and lower abdominal pain. Going back, her complaint started as extreme fatigability and intermittent episodes of epigastric pain started 3 years back and which increased for past 1 month. She also noticed loss of weight but no loss of appetite. During past 3 years, patient had intermittent episodes of itching over the peripheries, mainly towards the evening. History of similar itching during her 3rd pregnancy, and at that time, her blood sugars were found to be raised and she was started on tab metformin. Pruritus at that time was attributed to gestational diabetes. Patient had fair complexion and her relatives started noticing discoloration and pigmentation over her face and extremities over 2 years back. Later, she had excoriation over these lesions, hence consulted a dermatologist and was given topical application. Labs done at that time showed anemia, HB 9.8, ESR was raised, indirect hyperbilirubinemia, and SGOT PT were normal. She was referred to a physician in view of anemia, and her peripheral smear showed features of microcytic anemia, and patient was given iron supplements. At that time, her stool occurred blood was also positive, but stool routine showed endomoeba histolytic cyst, and she was treated for the same. But her symptoms of lethargy and tiredness persisted. Patient then developed pain lower legs, bilateral lower legs of the long bones associated with new hypopigmented lesions and increased itchiness over the extremities about 8 months back. She then developed swelling of right ankle joint with painful restriction of movements. Consulted a rheumatologist and labs showed RA factor and anti-CCP negative with raised ESR and CRP, mild anemia HB of 9.1 and mild indirect hyperbilirubinemia. Patient was treated as seronegative arthritis with steroids and HCQs and her symptoms subsided. So coming back, patient was apparently symptom free 4 weeks back. Then she developed intermittent fever associated with dysuria and abdominal pain. For that she consulted local hospital and was given antibiotics. During the course of fever, her all symptoms of bone pains and abdominal discomfort increased. Then her daughter working in Ireland became pregnant and she went there to look after her. After reaching Ireland, her symptoms improved. And for past 1 week, her fever again recurred as high-grade intermittent fever. Hence, she returned back to India for further management. No associated symptoms of cough, dyspnea, altered sensorium, vomiting, loose stools, low backache or reduced urine output. Past history, she is non-diabetic for 10 years on metformin, systemic hypertension for 10 years on tab amlodipine, dyslipidemia on atorvastatin for past 5 years, post-thyroidectomy done 30 years back on thyroxine supplementation, post-excision right breast lump done 6 years back, biopsy showed fat necrosis, no history of any other drug intake. Personal history, she is on mixed diet appetite and sleep reduced, bowel and bladder habits normal. Family history, mother and father were diabetic. Menstrual and obstetric history, menarche at 14 years, menopause at 50 years of age, and she is para 3, live 3. So, provisional diagnosis at this time is
any suggestions? Differential diagnosis.
Female patient, fatigability. She had a itching in pregnancy. With the history of pruritus, indirect hyperbilirubinemia, associated with pain, long bones. Then she underwent thyroidectomy also. So what are the, and she is having hypopigmented lesions in the leg, and more than that, the bystanders are telling സുന്ദരിയായിരുന്ന സുസ്മിത സെന്നെ പോലെ ഇരുന്ന് അവരിപ്പോൾ ഈ കോലത്തിലായെന്നാണ് പറയുന്നത്. സത്യമാണ്, ഞാൻ അവരുടെ കല്യാണത്തിന് ഞാൻ പോയിട്ടുള്ളത്, അതുകൊണ്ട് ഞാൻ പറഞ്ഞു. ഞങ്ങളുടെ ക്ലാസ്മേറ്റിൻ്റെ സിസ്റ്റർ. യെസ്, പോസിബിലിറ്റീസ് അറ്റ് ദിസ് സ്റ്റേജ്. പോസിബിലിറ്റീസ് തെറ്റുന്ന ഞങ്ങൾക്ക് ഇഷ്ടം, എന്നാലും ഡിസ്കഷനുള്ളൂ. ശരി പറഞ്ഞാൽ പിന്നെ ഡിസ്കഷനില്ല, അതുകൊണ്ട് തെറ്റേ പറയാവുള്ളൂ. അതുകൊണ്ട് or else we will proceed and see what is happening. ഒരു സ്റ്റേജ് വരെ കഴിയട്ടെ.
So from history, the provisional diagnosis is urinary tract infection, anemia, seronegative arthritis, type 2 diabetes, hypertension, hypothyroidism and dyslipidemia. After admission on clinical examination, the general examination showed pallor present, no icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Her pulse rate was 100 per minute, blood pressure 130/90 millimeters of mercury, respiratory rate 16 per minute, and patient was febrile. And on further examination, she had frontal alopecia and hypopigmented patches over the face and anterior aspect of legs. And systemic examination showed per abdomen suprapubic tenderness was present, no hepatosplenomegaly, and rest of the systems within normal limits. So we did the routine investigations for the patient, and HP was low. It was 8.4. Leukocytosis was present. ESR was raised. Altered RFT was present. There was indirect hyperbilirubinemia. ALP was raised. SGOT-PT were normal. Age reversal was present, and CRP was 113. Urine microscopy showed numerous vessels. And for UTI, the patient was started on broad-spectrum parenteral antibiotics, piperacillin, tazobactam, and her cultures were awaited. Urine culture sensitivity yielded the growth of E. coli sensitive to the same antibiotic. And it was followed by an ultrasound abdomen to rule out renal involvement, which showed right side pyelonephritis and GOOSE liver echo texture. Here the patient is diabetic with evidence of pyelonephritis. Hence, the antibiotics to be given for minimum of 2 weeks. And diagnosis at this stage is urinary tract infection, right side pyelonephritis from the ultrasound abdomen, and acute kidney injury because from the labs her creatinine has come down to 1.38 by the time of discharge. And there was anemia with indirect hyperbilirubinemia. Then there is parenchymal liver disease with raised ALP and age reversal. Then type 2 diabetes, hypertension, dyslipidemia and hypothyroidism.
Yes. So we want some differential diagnosis for this. So what are the differential diagnoses we will entertain? A patient with their history we will narrate it. Then what are the possibilities?
LDH was 10. Anemia workup, I will show it in the next slide actually.
Elevated.
Uric acid was normal.
Was the ANA done?
ANA was done. I will show it, it is coming in the next slide.
It is positive, sir. ANA is positive. That is one of the best sorted diagnosis because this patient is a young female. The complaint started in the younger age. Then she is having generalized itching, hyperpigmented lesions, loss of hair, then localized alopecia with patient is having involvement of mild involvement of kidney as well as liver. But the question, why there is an anemia of indirect anemia, which is of indirect hyperbilirubinemia? That means the indirect bilirubin is higher compared to the direct bilirubin, with no involvement of the liver parenchyma. That is an odd point regarding an autoimmune disease producing a liver disease. Once it is an autoimmune disease, naturally the parenchyma will be involved, jaundice will be there, it will be a direct hyperbilirubinemia. Then one more thing we have to settle, why there is acute kidney injury. We can say it can be due to pyelonephritis. Anything else with anemia, raised TSR, CRP positive, lupus nephritis, very good. It can be a lupus nephritis. Everything is because of lupus nephritis. But still, again the question, why the liver in this patient is involved, and without any parenchymal involvement, there is indirect hyperbilirubinemia as well as anemia. Yeah, that will be, we will come to it later. What about multiple myeloma?
What's the age?
Age is
64.
62, 63. Okay, proceed.
So anemia workup was done, and it showed MCV of 85, ferritin of 346, reticount was 4.5%. Peripheral smear showed normocytic normochromic blood picture with mild neutrophilia. Stool occult blood was negative. LDH was raised to 85, and serum B12 and folic acid were normal. So further, we calculated the reticulocyte production index, which is reticount into patient's HB divided by 15, which showed 2.52. So if reticulocyte production index is more than or equal to 2.5, it is hemolytic anemia, and less than 2.5, it is hyperproliferative anemia. Hence, this patient is having hemolytic anemia. And
this patient is having hemolytic anemia. For the benefit of the juniors, patient is having indirect hyperbilirubinemia, raised LDH, raised reticulocyte count, raised reticulocyte index. So these are the points that favors. One more thing, if we will do, that is more diagnostic, that is the level of haptoglobulin. It will be reduced in hemolytic anemia. Okay. Yeah.
During the history, the patient gives history of taking iron supplements actually.
After examining the peripheral smear, or after getting the serum ferritin then, or because of any other reason?
That details are not available with the patient. The available records says that. The same question she asked me, but my explanation for that is, by seeing the endomyoma histolytic and anemia in a small hospital peripheral setup, they started iron empirically. And the patient was pregnant also. So iron supplementation was given with some improvement. That may be the reason. But during that time, peripheral smear is not available.
But generally you expect macrocytosis in hemolytic anemia.
Macrocytosis can be there, that's all. Normocytic anemia can also be there, with some macrocytes in the peripheral blood. The normocytic anemia with the macrocytes can be present in the peripheral smear.
So with reticount raised, LDH raised, and indirect hyperbilirubinemia, we proceeded with a Coombs test, and direct Coombs test was positive. So it is a immune hemolytic anemia. And for autoimmune hemolytic anemia, it can be of warm antibody type, where the immunoglobulin G is raised, and cold antibody type, where C3 is normal or raised. And in this patient, her serum IgG was 1889, which was raised, and C3 was reduced. So we came to the conclusion of warm antibody type of autoimmune hemolytic anemia. So the treatment for autoimmune hemolytic anemias is first-line steroids, prednisolone 1 mg per kilogram, and to be tapered very slowly. And second line is rituximab, 100 mg weekly for 4 weeks. And RBC transfusion is indicated only if anemia is life-threatening, with ABO matched least incompatible blood. Next, The patient has immune hemolytic anemia and she has clinical features of non-scarring alopecia and hypopigmented patches over the skin. So we have to rule out the connective tissue diseases. For that, we have to do an anti-nuclear antibody immunofluorescence, and it came to be positive. And it was followed by a ANA profile, and ANA profile showed us anti-mitochondrial antibody positivity and double-stranded DNA positivity. And double-stranded DNA is specific for systemic lupus erythematosus. Now coming to the chronic liver disease workup, the patient has ultrasound showing coarse liver echo texture. There is mild rise in ALP with age reversal and mild thrombocytopenia. So shear wave elastography of the liver was done, which showed compensated advanced chronic liver disease and mild splenomegaly. So what are the causes of cirrhosis? We did a virology workup, anti-HIV IgM, HBsAg and HCV were negative. Serum ceruloplasmin and AFP were normal, and ogidoscopy showed Barrett's esophagus and duodenal ulcers. And here in the ANA profile, there is anti-mitochondrial antibody positivity. So we did a anti-LKM and anti-smooth muscle antibody. Both were negative, and patient is having normal SGPT and SGOT. So it rules out autoimmune hepatitis. And one test which can confirm the presence of anti-mitochondrial antibody in the patient is AMA immunoblot. And AMA immunoblot came to be strongly positive, and it is hallmark of primary biliary cirrhosis. So in this patient, the AMA immunoblot is strongly positive. So she is having primary biliary cirrhosis, and now it is called as primary biliary cholangitis, as the disease is it is a disease with cholestasis and progress over decades to lead to cirrhosis, which is a pre-terminal event. And anti-mitochondrial antibody is seen in 95% of cases of primary biliary cholangitis. Then we done a liver biopsy by our interventional radiologist, and the liver biopsy report showed portoportal fibrosis, which was suggestive of primary biliary cirrhosis, with no granuloma, no dysplasia or no interface hepatitis. The treatment is ursodeoxycholic acid, 13 to 15 milligram per kilogram per day, and next drug is obeticholic acid, 5 to 10 milligram once daily, and it is not to be given in decompensated liver disease. And if the patient develops decompensated liver failure, liver transplantation has to be done. So the final diagnosis here is patient is having urinary tract infection, right side pyelonephritis, acute kidney injury, primary biliary cholangitis, autoimmune hemolytic anemia, warm antibody type, connective tissue disease, probable SLE, duodenal ulcers, Barrett's esophagus, type 2 diabetes, hypertension, dyslipidemia and hypothyroidism. And few words on primary biliary cholangitis. It has a strong female preponderance. Median age of diagnosis is 50 years of age, and most will be asymptomatic and will be underdiagnosed. And only symptoms may be fatigue and evening pruritus, and there will be a mild rise in ALP seen, which will be missed by many. And AMA antibodies are present in 95% of patients with PBC, and cause is unknown, and it is characterized by portal inflammation and necrosis of cholangiocytes in small and medium-sized bile ducts. And pruritus during pregnancy is a risk factor to develop PBC, and giving ursodeoxycholic acid reduces the bile duct inflammation and can improve the lab parameters. But the risk of hepatocellular carcinoma is more in these patients than in normal population, and 10% of patients with PBC will have features of autoimmune hepatitis, which will be seen as interface hepatitis on biopsy with elevated IgG levels, and it is called overlap syndrome. Thank you.
So this patient came for a small thing, and finally they turned out to be a primary biliary cirrhosis.
Why did you put it as probable SLE?
Why did you put it down?
All the four criteria.
Huh?
All the criteria of SLE were not met. Euler ACR.
Anti-dsDNA is
DSDNA.
positive.
Anti-dsDNA is positive means it is sufficient to make a diagnosis of SLE.
It is sufficient.
SLE, sufficient.
The other thing is regarding the renal failure. Usually in females with ANA positive SLE, after the urinary infection is controlled, did you do a 24-hour urine protein estimation? Because lupus
24-hour urine protein estimation was done, and it was below normal range for the patient actually. Her renal parameters have improved actually.
was normal.
No.
Any other comments or suggestions? Okay, because lack of time, we will go on to the next case.
Next case will be presented by Dr.Akshara, our first year resident. The topic is a wild goose chase. Over to Dr. Akshara.
Good evening, everyone. My case is a 43-year-old lady from Muvattupuzha who presented to our casualty with complaints of severe headache, fever, persistent vomiting, giddiness, severe vertigo, nystagmus, and nasal regurgitation. So this patient was on treatment from various hospitals in the city, and with no improvement in symptoms, she was finally referred to Vellore Hospital, on the way to which she came to our casualty. So accidentally being the admitting unit that day, she was admitted under us. So the whole story...
ടിക്കറ്റ് ബുക്ക് ചെയ്ത് തലേ ദിവസമായിരുന്നു. പേഷ്യൻ്റ് വന്നത് പിറ്റേ ദിവസമായി. ട്രെയിനിൽ കയറാൻ നോക്കി കഴിഞ്ഞപ്പോഴാണ് അറിയുന്നത് ടിക്കറ്റ് ഇത് കഴിഞ്ഞു പോയത്. So they got admitted in our hospital.
So the whole story started last year on October when she first presented to our gastroenterology OPD. Then she had complaints of abdominal discomfort, excessive thirst, polyuria, and excess intake of fluids, all of which lasting for 3 months duration. The only comorbidity the patient had was she was a non-case of type 2 diabetes mellitus. So in view of the presenting complaints she presented, she was referred to an endocrinology OPD. On routine lab investigations were fairly normal. Urine routine was normal with no glucose urea. We did a urine osmolality which was of lower range, 114 millimole per kg, and a serum osmolality of 302 millimole per kg. Considering the low urine osmolality, patient was taken up for a water deprivation test.
Yes, what is the probable diagnosis? Very good. Very good. Diabetes insipidus. Okay.
So the water deprivation test results are as follows. It showed a persistently low urine osmolality even after water deprivation and a rise in the urine osmolality after desmopressin administration. So to clinch the diagnosis, we did an MRI brain with pituitary gland which showed a reduce in the size of normal T1 hyperintensity of the posterior pituitary gland. So the most probable diagnosis diabetes insipidus. As usual, the patient was started on nasal desmopressin spray and her condition improved. But patient on the course of this treatment, she was complaining of diplopia more on looking towards the right. For this complaint, she was referred to a higher ophthalmology center where the ophthalmologic examination revealed a right sixth nerve palsy.
Yes. What is the most probable diagnosis in this stage? Diabetes mellitus, diabetes insipidus patient. Now coming with a history of sixth nerve palsy. Diabetic mononeuritis is the most probable diagnosis. Cause can be due to various reasons. Okay.
So most commonly, diagnosis can be an ischemic mononeuropathy. These are some of the most common causes of mononeuropathy. Probably diabetes, sarcoidosis, or vasculitis to be ruled out. The patient again was referred to a neurologist for further workup. They did the workup for all the autoimmune, vasculitis, sarcoidosis workup. IgG4 was normal, C3, C4 within normal limits, RF factor negative, anti-CCP negative, ACE levels within normal limits, C-ANGA and P-ANGA normal. So nothing conclusive was obtained from the lab investigation. So she was advised an MRI brain contrast. But the patient, very disappointed with the lab investigation, she went into another multi-specialty hospital in the city. By then, she was having a new set of complaints with slurring of speech and deviation of angle of mouth.
Along with the systemic palsy.
Again, in the new hospital, her routine labs were investigated. Routine labs showed a significant rise in total count with a rise in CRP. Other blood parameters were normal. So they went ahead with an MRI brain stroke protocol. The MRI brain stroke protocol doesn't show any acute infarct or significant steno-occlusive disease. So the patient was labeled with vestibular hypofunctioning, and she was advised vestibular rehabilitation exercises and prescribed tab vertin and tab stemetil. Patient again disappointed with no improvement in symptoms, again went to the next hospital in the city, where again her routine blood investigation showed a rising total leukocyte count and a rising CRP. So here she went a series of extensive investigations. Blood smear done showed peripheral smear showing normocytic normochromic blood picture with neutrophilic leukocytosis and thrombocytosis. Again, IgG4 was done normal, HLA-B5 negative, ANA done was negative, ACE levels repeated were normal, blood cultures were sterile. They did an MR brain limited sequence which showed no acute infarct or hemorrhages. Echocardiogram done was fairly normal. USG done showed hepatomegaly with grade 1 fatty changes. By then, nothing was conclusive from the investigation. Patient was deteriorating in her condition. She was having slurring of speech, severe headache, photophobia, difficulty in swallowing, and persistent vomiting. So they decided to go for an MRI contrast study. From the MRI contrast study, there was a moderately enhancing diffuse pachymeningeal thickening involving the right posterior temporooccipital convexity, right tentorial leaflet, posterior cranial fossa, and dura of the upper cervical spinal cord, all pointing towards a hypertrophic pachymeningitis. And also there was a reduced bright spot of the posterior pituitary. Also, a PET-CT imaging was done, which was consistent with the MRI brain contrast results. Also, she had an FDG-avid hypodense nodule involving the isthmus of thyroid gland, probably an incidentally detected thyroid malignancy also. So, considering the possibility of a meningitis, she underwent a CSF study. Total count were checked. We went for a biofire in the CSF study, gram staining, AFB staining, gene expert, culture and sensitivity. So comprising all the CSF study, the appearance was clear. Total count of 100, predominantly lymphocytic, with high proteins, normal sugars. Biofire panel done on CSF was negative. TB gene expert study done was negative. Culture and sensitivity done was negative.
In this stage, or in this context, what are the possibilities in this patient and what else is to be done in this case? Fungal culture results is coming. Okay. Anyhow, I think there is no dispute or doubt regarding the diagnosis of meningitis. And it is a pachymeningitis. So one thing is sure. From the results, what are the other possibilities? One is fungal, of course, ready. Then, yes, very good. Tuberculosis, definitely. Tuberculosis, 100 cells are there, mostly lymphocytes, definitely. Even though gene expert is negative, we cannot rule out tuberculosis. And third, yes, definitely. Sarcoidosis. Sarcoidosis comes into the differential diagnosis, definitely. Because since gene expert is negative, but the typical picture, sugar is normal. That is a point against tuberculous meningitis, but in favor of a sarcoidosis. Okay, good. Sarcoidosis. Then, yes? ഇതിനെ ഒരു ആക്റ്റീവിനും ജീവനും വെക്കണമെങ്കിൽ കുറേ ഒപ്പീനിയൻസ് വേണം, തെറ്റ് വേണം, എന്നെങ്കിലേ പറ്റൂ. വെരി ഗുഡ്, വെരി ഗുഡ്. ആരത് പറഞ്ഞു? വെരി ഗുഡ് സാറേ. 10 points. Partially treated meningitis. Very good. This patient, in the course of event, because he has received lot of antibiotics. So a partially treated meningitis, this is the typical picture. Typical picture. So a partially treated meningitis is one of the best diagnoses in this patient, because the patient is treated in different hospitals, that too major hospitals. The yatra started from Moattura. He's our neighbor. Okay. Yes, then. പിന്നെ പോസിബിലിറ്റീസ് ഇനിയുണ്ട്. ആക്റ്റീവാ സാറാ, സാറൊന്ന് ആക്റ്റീവായല്ലേ സംഗതി ഉഷാറാവുള്ളൂ. യെസ്, ഓക്കെ, വിൽ move to the next stage. So these are the possibilities we are considering at this stage. Okay. Because of the multiple cranial nerve pulses. Okay, come.
So diagnosis of meningitis was almost confirmed. We were on lookout for the etiology for this. Patient's health condition was still
This
deteriorating.
workup is done in another hospital very extensively.
She started having difficulty in swallowing, difficulty in walking and getting up from the bed, hoarseness of voice, high-grade fever was still persisting, and disorientation. So a laryngoscopy was done, which showed left vocal cord palsy and sphenoid sinusitis.
One more problem, that is the vocal cord paralysis. Okay. And sphenoidal sinusitis. You know that, മറന്നു പോരുത്, sphenoidal sinusitis the location with an abscess formation, അല്ലേ?
Patient was admitted there in ICU. She was undergoing pulse steroid therapy and appropriate treatments initiated. The details of the treatment are not available. Despite all these investigation and treatment, patient was not clinically improved. She was discharged at request and was going to Vellore when she accidentally came to Lisie. So the challenges in front of us: 43-year-old lady, known case of diabetes mellitus, first presented with diabetes insipidus, fever, diplopia, probably 6th nerve palsy, slurring of speech, angle of deviation of mouth suggestive of 7th nerve palsy, difficulty in swallowing, dysphagia, 9th and 10th nerve involvement, MRI brain showing pachymeningeal thickening, and probable thyroid malignancy. So lower cranial nerve palsies, some of the DDs can be genetic causes, vascular ischemic strokes, aneurysms, trauma, base of skull fracture, infections, inflammatory conditions, metabolic diseases like diabetes and neoplasms. So considering the CSF study and the MRI brain contrast study, the most probable differentials that we were looking out. First one, which is most common in our place, tuberculosis, autoimmune conditions, chronic infective conditions, and diffuse carcinomatosis.
When patient came to our hospital, patient is having multiple lower cranial nerve palsy starting from 6, 7, 9, 10, etc. with the left vocal cord paralysis. So thinking that it is one thing is sure, it is a pachymeningitis, and since lower cranial nerves are involved, we diagnose it as a basal meningitis. Then the task is to find out what is the cause. So regarding basal meningitis, the most important causes in our place are tuberculosis stands first, autoimmune next, then chronic infective conditions. Lot of other infections are there. Then diffuse carcinomatosis. These are the 4 major possibilities. Okay.
Our routine investigation showed raised total counts, neutrophilic leukocytosis and raised CRP. We did a blood culture which was sterile, a fungal culture which was sterile. Sputum for fungal filaments done was negative. Autoimmune workup, ANA negative, C3Z4 normal, RF factor negative. Vasculitis workup, C-ANGA, P-ANGA was negative. For TB, we did a MANDU which was negative. IGRA done was negative, and sputum TrueNAT done was negative.
So this patient, the fungal, we thought it can be a fungal meningitis. That was our first diagnosis. The test for fungal diagnosis done in the previous hospital also was negative. So here we did the fungal culture and fungal filament study. Fungal filament study will yield more than 80% diagnosis of a fungal disease. And the other relevant investigations like for sarcoidosis and other things she already discussed are negative. So fungal meningitis is out. Tuberculosis is out as far as the present situation is concerned. Then what is remaining is carcinomatosis. So we proceed.
For suspecting chronic infections, we did a toxoplasma, brucella, chlamydia, wheel Felix test. All of this was negative. Finally, we did the test which led us to the diagnosis.
Yes. What else is? This case was easy for workup because she came with almost all the reports. So our main task was to sit down, compile all the results, and to discuss and reach into a diagnosis. So one test we ordered that clinched our diagnosis. Yes, yeah, FNAC thyroid was done, it is suggestive of malignancy. One thing, yes. Thyroid malignancies are very notorious for diffuse carcinomatosis, everybody knows. So that is one strong possibility we considered. And we referred the patient to surgeon, and he told us we will go for surgery immediately. Oncologist consultation were done, and then we planned for a surgery in this patient. Okay. And meanwhile, we have shown the patient to neurologist, neurosurgeon, gastro, and critical care person also, once the patient's condition worsened during that time. Okay.
So the one test.
So one test, come. Yes, which is the test, and what are your suggestions to do any test? അതിന് മുമ്പിലത്തെ ടെസ്റ്റ് ഒന്ന് എടുത്ത് ടി വിയുടെ ടെസ്റ്റൊക്കെ ഉള്ള
CSF study.
ടി വിയുടെ ടെസ്റ്റൊക്കെ പറയാം. കഴിഞ്ഞ 2 സ്ലൈഡ് പുറകില്ല. ഒന്നോടെ പറയും, ഒന്നോടെ അത് കഴിഞ്ഞിട്ട് യെസ്. So these are the workup we have done. All these tests, fungal culture, blood culture, then fungal filaments, autoimmune workup, because autoimmune is another commonest cause for basal meningitis. Then vasculitis is definitely arachnoiditis, vasculitis we ruled out. TB workup, whatever things possible we have done. Okay, what else we want to do? Which one? I-131, only after surgery it has got a role to find out whether total thyroid tissue is removed or not.
So the one test which we did was serum galactomannan, which came out to be strongly positive with a value of 3.39.
So once this test is positive, it is confirmatory for aspergillosis. So patient is having a fungal basal meningitis, aspergillosis. So this patient was already given date and fixed for meningeal biopsy and surgical intervention, but by seeing this result, we postponed it.
Because of strong suspicion of fungal etiology, serum galactomannan was sent, which came out strongly positive. Soon we started the patient on IV voriconazole. The neurology advised for a meningeal biopsy, which was deferred to assess improvement with the antifungals. ENT consultation was sought for nasal block and headache. DNA done showed left sphenoid ostium not visualized with abscess, suggestive of sphenoid sinusitis.
So this patient was having a sphenoidal abscess, large abscess. That is why she was running with a very high temperature every day. Okay.
Patient from the ENT side was planned for FES and septoplasty, but with antifungal treatment, patient showed significant improvement. CTPNS taken later showed total clearance of the sinuses, and MRI brain taken later showed significant reduction in the dural thickening and enhancement, which was suggestive of ongoing resolution.
So she becomes afebrile, her headache subsided, heaviness subsided, and all the cranial nerves started improving, started taking food, Ryle's tube removed, and all such things with the treatment with the antifungal drugs. Diplopia recovered. Diplopia also recovered. It's the last thing to recover, but diplopia also totally recovered. The patient was here in our hospital for about 1.5 months.
Patient now clinically better, afebrile, nasal regurgitation improved, no difficulty in deglutition, diplopia disappeared, and 7-hour paralysis was improving.
A patient, she is now promoted as assistant director of local bodies. Government servant.
A cytology was also done from the thyroid swelling, which was suggestive of malignancy. So patient is also planned for total thyroidectomy now. Coming to the treatment of aspergillosis, antifungals active against aspergillosis include voriconazole, itraconazole, posaconazole, isavuconazole, caspofungin, micafungin, and amphotericin B. Initially, IV administration is preferred for acute invasive aspergillosis and oral administration for all other diseases. We started the treatment with IV voriconazole, doses 6 mg per kg every 12 hours IV or 400 mg every 12 hours per orally. For a maintenance dose, 4 mg per kg every 12 hours IV or 200 mg every 12 hours per orally. Thank you.
Yes.
Literature supported.
Ketila.
Pachymeningitis, aspergillosis presentation. He said literature supported.
4 cases. 4 cases reported. This may be a 5th case. There may be a lot of cases which is not reported.
How will you explain diabetes insipidus?
Diabetes insipidus we cannot explain by this meningitis because she has not shown any improvement for her diabetes insipidus. We don't know whether she will improve after some more time. Diabetes insipidus is a separate entity. She was having diabetes insipidus for the last 4 months. Almost a year. She first came to Lisie Hospital. From there, she went to some other hospital. From there, she went to some other hospital. Then, on the way, she came to Lisie again.
So this direct luminant test, was it done in the serum?
It's very non-specific, no?
No.
Even if it is from the lungs, it can become positive. If there is invasive aspergillosis anywhere, it can become positive.
Yeah, definitely. Anywhere invasive aspergillosis is there, it will be positive. But here the patient's invasive site is brain and meninges because from the clinical picture. No other area is involved. So we think that the invasion is in the meninges producing all these clinical features.
It's not a...
The origin being in the sphenoid sinuses because that abscess also totally cleared with the antifungal treatment.
What is the cause for this aspergillus in her? Is he immunosuppressed? What is the cause for this severe infection in this young lady? Is there any cause for it?
She is already having uncontrolled diabetes for another 4-5 years.
We are having so many diabetics here.
Yeah, she was on steroids also.
Because of this disease only they put her on steroids?
Fungal infections we will see usually in patients having some systemic illness or immunocompromised diseases or on steroids or mostly in
She was put on steroids because of this illness or any other thing?
She had COVID. She had COVID twice. Because she was in the forefront of fighting against COVID. That may be one reason. That also we discussed. They are publishing it saying that it can be a...
We'll move on to the next case. Next case will be presented by Dr. Dayana, our second year resident. The topic is Tale from Malta and a lesson for us all. Dr. Dayana, please.
Good evening all. Tale from Malta. Ours was a 34-year-old male hailing from Udayapuram, Muattura, working in Malta for last 4 months with no prior comorbidities. His symptoms started as fever and myalgia with fatigability. He took treatment from Malta, but after 1 week, he noticed black-colored sticky stools and later frank blood in stool. He again consulted doctor there, did proctoscopy and ruled out any local causes of bleeding, advised endoscopy and colonoscopy for further evaluation. His symptoms persisted with a high-grade fever with chills and rigor. Patient noticed severe weight loss of around 30 kg in a month and loss of appetite. He was emaciated and was even had difficulty to walk without support. Since there were no relatives, friends not forced him to return back to Kerala and continue treatment here. Hence, he got admitted in a major hospital in his locality. As per records, on examination over the other center, patient was conscious oriented. There was pallor, bilateral pedal edema, vitals were stable, and there was lower limb cellulitis. Blood reports showed pancytopenia, HB5, WBC count of 3180, platelet count of 1,11,000 and stool OB positive, serum iron was 23. Yes, missed. Actually 1,11,000. Peripheral smear was showing a pancytopenia, deranged PT-INR, and there was hypoproteinemia, severe hypoalbuminemia, which was serum albumin level was 1.5.
Very low albumin level.
Radiological investigations done in the outside hospital was showing chest X-ray within normal limits, echo was normal and ECG was also normal sinus rhythm. In USG abdomen, increased echogenicity of mesentery with multiple enlarged mesenteric lymph nodes in the upper abdomen. CT showed hepatosplenomegaly with moderate ascites, anasarca, left-sided pleural effusion, few large mesenteric non-necrotic nodes, which was a differential diagnosis of abdominal coats. OGD was showing large duodenal ulcer, Forus grade 3.
Yes.
The colonoscopy was normal and his other investigations showed IGRA and Mando negative. So our patient, young male with fever, severe weight loss, anemia, GI bleed, left-sided pleural effusion, anasarca, hepatosplenomegaly, ascites, large mesenteric non-necrotic lymph node.
Yes. So what are the possibilities we have to consider? In this stage, suppose we are treating the patient, what else we will think? Yeah, first is tuberculosis. Agreed, sir. 100% agreed. Because all the findings we can explain except 1 or 2. That is severe thrombocytopenia, difficult to explain by a tuberculosis. Then leukopenia. Though lymphoma, very good. Lymphoma is a second very good possibility. Very good. Brucellosis, definite. Brucellosis. Brucellosis, plain brucellosis, we cannot explain everything, but still is from Malta. And we all heard about Malta fever. Malta fever, what is Malta fever? Brucellosis. Okay. Okay, what else? Yes, possibilities. HIV, very good. HIV will explain everything. All the things will be explained by HIV. HIV is a very good. Our suggestion is very good. Yes. സാറിൻ്റെ ഇന്ന പ്രതീക്ഷ ഇനി അല്ല കം ഓക്കെ ദെൻ പ്രൊസീഡ്.
The diagnosis made in the outside hospital was anemia, GI bleed, query abdominal coats, malabsorption.
So they made a diagnosis of malabsorption syndrome and
He was managed with 10 units of PRBCs, 14 FFP transfusions and multiple albumin infusions. In view of noticed cellulitis, he was treated with amoxicillin clavulanic acid and metronidazole. But due to persistent GI bleed and fever with weight loss, he was referred to our center for further evaluation. On our examination, patient was drowsy, disoriented, emaciated with bilateral temporal and cheek hollowing, febrile with one.
By that time, he lost around 35 kilo weight. 35 kilo weight over a period of 2 months.
Febrile, BP was 120 over 70 millimeters of mercury and pulse rate was 98 per minute. Saturation was well maintained and respiratory rate was 26 per minute. There was severe pallor, poor oral hygiene with stomatitis. There was no icterus, no clubbing, no generalized lymphadenopathy. Bilateral pitting pedal edema, abdominal wall edema with generalized anasarca was there, and there was ecchymotic patches over extremities, petechial hemorrhage and EC bruisability. His baseline investigations showed hemoglobin of 5.4, ESR 2, total WBC count of 2700 and platelet count of 81,000, elevated CRP and procalcitonin levels was negative. Transfused with 2 unit PRBC concentrate after taking blood for relevant further investigations. The peripheral smear showed normocytic normochromic anemia, moderate neutrophilia, marked thrombocytopenia. He was positive for direct Coombs test, most likely due to multiple blood transfusions. In view of severe anemia, proceeded with further iron profile and ferritin counts was 604.
Why? Anemia due to chronic illness. Okay, correct.
Chest X-ray showed
results ഒക്കെ ശ്രദ്ധിച്ചോണേ.
Chest X-ray showed a left-sided pleural effusion and pleural fluid analysis revealed a transudative nature with a lymphocytic effusion. Pleural fluid ADA was 29 with a negative for gram stain, AFB fungal stain and MTB TrueNAT was negative. The pleural fluid culture showed an exterior Klebsiella growth and antibiotics were modified according to the sensitivity pattern. His stool examination showed a pus cells and RBCs. Even after 5 days of antibiotic, patient condition was not improving. He became restless, disoriented with intermittent crying spells and emotional outburst. Decided for further investigations, he was evaluated in detail for and those investigations was non-reactive for H. pylori, HIV, HBV, HCV, HSV, CMV and toxoplasma. But he was reactive for Brucella IgM and negative for IgG with a significant titer. He was started on doxycycline considering his diagnosis of brucellosis.
Only one test came out to be positive, that is Brucella, that is Malta fever. So, okay, proceed.
His IGRA levels were positive. His blood, urine and stool cultures were sterile. He was then investigated for autoimmune etiology. Serum cryoglobulins were negative, Cienga, Pienga negative and ANA profile was also negative. Meanwhile, patient again had marked HB drop with bleeding from GI tract. A hemoglobin dropped from 7.8 to 4.9 with further 3-4 episodes of malign and hematochezia. In view of obscure GI bleed, capsule endoscopy was done which showed a small bowel bleed. CT angiogram was taken which showed no radiographic evidence of active bleed. He was posted for push endoscopy on 7th March and was showing a duodenal ulcer 4S3, gastric mucosal edema with biopsy showing features of focal mucosal erosions, and foveolar hyperplasia. Since he had intractable bleeding, he was further investigated for hemorrhagic disorders. Bleeding time, clotting time was normal. Fibrinogen levels were low. D-dimer was elevated.
So
this clinches the diagnosis.
Yeah. So this is the stage of the patient. The patient condition was deteriorating day by day. Every day we are in trouble. Patient condition is going down like that. So this is the stage. Still then we have got no diagnosis except that brucellosis was positive. Yes. What else? What is the diagnosis? HLH. Yes. One strong possibility. How will they explain all these findings?
Maybe secondary to that?
No. Fanconi is very difficult to explain the severe anemia, thrombocytopenia, bleeding tendencies, decreased fibrinogen level, then increased ferritin, all those things. Very difficult. And the condition, bleeding from the GI tract, all those things we have to explain in one diagnosis. Egypt, no, only Malta.
Bilharziasis and things like that.
Bilharziasis, yes. We thought that possibility also, but he is denying that he went there. When a stool examination was normal for us.
Okay. Because that can affect the intestine, it can cause...
Yeah, this type of picture. Okay, what is your name, doctor? Arati, okay. Yes, proceed.
One clinical investigation made the final diagnosis. The bone marrow biopsy was done and sent for analysis. Bone marrow aspiration report showed features of hypercellular bone marrow with normal erythroids, myeloid shift, mild increase in plasma cells, diffuse increase in reticuloendothelial cells, and some showing hemophagocytosis. Diagnosis: all the features were in favor of macrophage activation syndrome, hemophagocytosis, and which is secondary to brucellosis.
So this is the final diagnosis. HLH. She made a correct diagnosis. She suggested one possibility as HLH. HLH is a strong possibility, and with this diagnosis, the entire scenario was changed. HLH was the diagnosis.
He was treated with pulse steroids, cyclosporin, broad-spectrum IV antibiotics, PRBC and plasma transfusions, IV human albumin, oral protein supplements and other supportive measures. His condition markedly improved and was shifted out of ICU to ward. Later, he developed a vitreoretinal complication which made us refer out the patient for expert management.
Refer the patient to a vitreoretinal surgeon.
Macrophage activation syndrome is a severe inflammatory systemic abnormality with lethal potential characterized by pancytopenia, coagulopathy, hepatopathy, neurological disorders, and hemophagocytosis. The inflammation is caused by the uncontrolled activation of the macrophage and T cells. Mortality has been reported in 20 to 53% of cases. In our case, the diagnostic criteria for HLH is the Histiocyte Society criteria, and the meeting more than 5 of the following 8 criteria was suggestive of hemophagocytic lymphohistiocytosis. For our patient, we had fever, splenomegaly, cytopenias, increased ferritin levels, and hemophagocytosis on biopsy.
So, biopsy of the bone marrow is the confirmatory to make a diagnosis of HLH. We find it very difficult. The entire team worked hard for the diagnosis, and ultimately we got this. Every day he came with some diagnosis, and we find it to confirm it. Finally, they made a diagnosis, and the patient improved very well over a period of stay of same things, nearly 1.5 to 2 months. He is a young patient, 25-year-old, from a fairly good financial background, went to Malta for higher studies, but now came with all sorts of problems. No idea, sir, regarding that. Malta, contact is enough. No need to drink milk. Only contact is enough to get brucellosis. But it is very common there. When going back to the literature, it is very common in Malta. Okay. Any other comments? This patient also referred from a higher center, big hospital, with all relevant investigations. So very easy for us to make a clinical diagnosis. So better to send all investigations with the patient while we are referring the patient, so that very easy for the other hospitals to make a diagnosis. We send entire file to the hospital to which we refer the patient for further management.
Brucellosis, how common in our settings at present?
Brucellosis is very common, sir. Brucellosis is not only an uncommon disease. We are commonly seeing lot of brucellosis while investigating PUO cases, but without much complications.
What is the common presentation?
Presentation PUO.
PUO.
You are also PUO. I have seen all cases of brucellosis as while working up for PUO. In medical college also we made a registry, brucellosis.
We would like to at this juncture, we would like to briefly mention regarding one more case which we had, and at the similar picture of macrophage activation syndrome. She was initially treated for polyarthritis. We did a knee aspiration, inconclusive. Towards the end of the hospital stay, her titer value for toxoplasmosis was very high. We treated her for toxoplasmosis. She stayed for over 3 weeks. Treated for toxoplasmosis, discharged. She was doing very well. She came for first follow-up with her. She was doing well. She came for the second follow-up. She turned out to be quite sick. Same day she was, till the discharge time, her renal and liver parameters are normal. But on the second follow-up, her creatinine just jumped to 3. Bilirubin levels jumped to 3. She was very sick on the same day. And by the same evening, or by the next day or so, or the middle of midnight or early morning, 3 a.m. or so, she was intubated. She struggled the next day. By the third day, she died. The only thing in that patient we could not do was a bone marrow, but then again, clinically, after discussion with multiple experts, it was decided that she too was going through a macrophage activation syndrome. Probably, was it due to toxoplasmosis or was it a drug-induced? Remains a mystery till this day, because we did not have the time to go ahead with the bone marrow. Although most of biochemical parameters, as we discussed before, the criteria, it met the criteria. The only final confirmatory criteria, the bone marrow could not be done. Had she been clinically stable, we would have done it. It was a very stormy course.
And critical care people took over the case. Meanwhile, our DNB resident Akshara.
This could be a case of macrophage activation syndrome also, sir.
Just like Aradi, she made a diagnosis. Akshara telephoned to me at 6 o'clock saying that, sir, we got one more case, it's a problem case. Sir, will you please come? When I reached there, triglyceride is high, ferritin is very high, fibrinogen level is very low, and we made a diagnosis of macrophage activation syndrome. But because the patient was very sick, we could not do a bone marrow. But we shown to all specialists and all treatment, what all possible we did, including the steroid therapy, everything. But we could not save the patient.
Moving on to the next case, the topic to be presented by Dr. Sanal Babu, our first year resident. He will be discussing concerning notorious baby bites.
Good evening all. So let's go to the discussion. Our case is a 34-year-old male who is a plumber by profession. He's a well-built man who was a bodybuilder too. He was on mixed diet. 2.5 months back, he was presented with the left metatarsal joint pain, restricted the range of motion, and tenderness was present. And he was also having mild fever, myalgia, and headache, which was intermittent. and he visited a local physician near his home, and vitals were somewhat stable with high temperature was there. He was having fever, BP was stable, and SpO2 was 97% in room air. On examination he was feverish and joint tenderness was also present, and systemic examination was not having any significant findings, and on labs he was having leukocytosis, high ESR, urine routine examination showed no significant finding, and high uric acid levels, and symptomatic management was given. 1 week later he presented with multiple joint pains including bilateral wrist joints, elbows, metacarpophalangeal joints, proximal interphalangeal joints, shoulders, knees. Patient was not able to sit cross-legged or walk or doing his daily routines or do his jobs and other things, and he was referred to the nearby government medical college. There he was seen in the casualty and referred to the physician, and they noticed to have a left knee swelling along with other joint problems, and they recorded it as other joint deformities were also present. There was gross swellings, and temperature was found to be high, 101 degree Fahrenheit, and his heart rate was 100 per minute. And here raised TLC and ESR found to be more than 120, that is specifically it is written 120 ESR. And his uric acid levels were elevated that time also. He was given oral antibiotics, febuxostat and steroids, and he was sent home with the advice of test for rheumatoid arthritis factor and sent home. He went back to home, and he came back after 1 week with similar complaints. There was no relief to the complaints, and RF factor found to be in normal range. This is the test result. RF factor was in normal range, and treated as a gouty arthritis or seronegative rheumatoid arthritis. He was sent home with indomethacin, febuxostat, Visalon and methotrexate. Took medication for 2 weeks. Patient had intermittent episodes of fever that time. Myalgia was continuing, and no change in any severity of joint pain.
So, this point of time, the diagnosis, what is your opinion? Agreeing or any difference of opinion? This is just for clinical discussion. Yes. Otherwise, everybody will sleep and it will go. Quick, yes. Agreeing. Rheumatoid arthritis or seronegative arthritis, gout, agreed. CCP negative.
CCP was not done during this time.
Not done.
Yes, sir. Symmetric joint involvement.
Yes. So, seronegative arthritis, gouty arthritis, presented with polyarthritis. Okay. So,
And this was the prescription. It was having methotrexate and febuxostat, indomethacin, Visalon and folic acid, and continued medication for 2 more weeks, and his symptoms were persisting, and he came back with increased left knee swelling, and they have done a patella tap, and it was positive, and knee was aspirated. There was no crystal, and the aspirate was sterile. And that time, after 4 weeks of therapy, the uric acid found to be 5.2 and ESR was 62, still raised, and treatment continued, and they added a cefixime and piperacillin tazobactam, suspecting an infective etiology there. This was the prescription, and he was advised to continue the treatment in the local hospital because of the distance, and he came back, and he had that fever recurring again and again, and myalgias were present, and multiple joint pain still not relieved. Visited orthopedician and physicians outside the locally, and took short courses of antibiotics again, continued methotrexate. Symptoms recurred with mild fever and myalgia. Then after that, he gone to a major hospital in Ernakulam, investigated thoroughly. RF factor was done, anti-CCP was done, HLA B27 and uric acid levels were done, viral serologies, thyroid profile and ANA immunofluorescence was also done.
What happened to it? Negative?
The results like viral serologies were negative, HLA B27 not detected.
Yeah, so all these tests were negative.
ESR was still high, anti-CCP was also negative, rheumatoid factor again negative.
CPK, yes.
CPK was normal only. Syphilis was not done, sir.
Syphilis not done because we are not seeing any case of syphilis. Yes. When when I was a student in Kottayam Medical College, the first diagnosis and first test is VDR. Great. So, urine routine, how is the urine routine?
That time urine routine was normal only.
Normal.
No significant findings were there.
Yes. So, septic arthritis, seronegative arthritis, gouty crystal arthropathy, then reactive arthritis. These are the 4 possibilities for which patient underwent treatment. Anything else? Though? Gonococcal always monoarthritis. Monoarthritis. It is a polyarthritis present in all joints. Okay.
He was continued treatment there. He was continued with the methotrexate, and they have added hydroxychloroquine and sulfasalazine also with the methotrexate, and he was sent home. Continued the treatment, and no significant improvement was there, and planned to add next line of treatment, that was biologicals, and the patient wanted to get discharged due to financial constraints, and discharged, gone for Ayurvedic treatment after that. And he was treated as variant of Amavada according to him, and during the treatment patient developed breathlessness, fever recurred, as they couldn't explain why fever was occurring and breathlessness was there with Amavada, and they suggested for an allopathic treatment after that. Patient was taken to local hospital with high fever, multiple joint pain, inability to walk, and occasional breathlessness, referred to higher center in suspicion of infective endocarditis from there.
This patient was taken over by Rotary people, and our Ajay Kumar sir referred the patient to us. So the financial constraints. He was referred as infective endocarditis. And he came to our casualty. We first this was seen by cardiologist, and they told it is not infective endocarditis, so we won't take over. The condition of the patient was also not good. He was brought in the ambulance, not able to get up, not able to walk, almost in a bedridden state.
He came in, like Sir said, he came in an ambulance, but no signs of infective endocarditis was there in physical examination, and no breathlessness was there at that point. SpO2 was 96, and he was maintaining it in room air, and palpitation was present, and heart rate was 120 per minute. His BP was on a lower range. Then on examination, bilateral wrist swelling were there. There was no left leg knee swelling at that time, and bilateral mild crepes were heard. And on laboratory examination, again he was found to have high ESR, TLC was normal, urine routine examination showed mild hematuria there, mild transaminases with elevated alkaline phosphatase levels, and mild AG reversal was also noted.
With this, it's a chronic arthritis with a total count normal. So septic arthritis is out of question in this patient. And mild hematuria, transaminases are elevated. Sometimes it can be due to drug or due to the disease process itself. Okay.
In suspicion of infective endocarditis there, we have done an echo and blood cultures were done, and essentially both of it was sterile, and echo was a normal study. In view of rise DSR and AG reversal, serum protein electrophoresis was also done. No monoclonal band was also noted. Repeated RA factor was done, anti-CCP and ANA immunofluorescence was done in our hospital. No significant findings noted. That time uric acid levels were only 5.9.
Urine showed hematuria, high ESR, reactive arthritis. Sometimes only a transesophageal echo will pick up.
Transesophageal echo was done in this patient. Yes, because of strong suspicion, cardiologist done and transesophageal echo at free of cost, and it was normal. Yes, then. Okay, how we proceeded is, we decided to do, all investigations done in the higher center, in the center where he was admitted, and all autoimmune causes, rheumatoid arthritis, SLE related, ANA related, vasculitis, everything is ruled out. So we decided to send for 2 investigations. One is CRP, other is a procalcitonic. Here, the procalcitonic came out to be strongly positive. So we thought it can be an infective disease. That is the scenario where we shifted from autoimmune or rheumatoid arthritis to a different setup.
His fever was recurring again and found to have, like sir said, CRP was very high, 190, and Procol was also positive. Started on a wide spectrum antibiotic, and still we were on doubt because fever was recurring. Then we were asked to do a thorough physical examination and a good history we had to take. And on thorough examination, patient had a healed ulcer that was of 1 to 2 centimeter in dimension on upper chest. And when we asked about the history, he was a plumber, like I told, and had a contract work in a village, developed fever with joint pain after 7 days of it. There was an ulcerative lesion appeared in the chest, healed by itself. Similar lesion was also in the right inguinal area, and on examination there was also a healed ulcer noted, and also gave the history of multiple papular rashes all over the body.
Now the cat is out. Yes. Para? Scrub typhus one possibility. CPK? Normal. Anything else? Yes. Come out. ശരി ടൈമില്ല ഒരെണ്ണോടെ സമയം 10 മിനിറ്റോടെ ബാക്കിയുള്ളൂ.
Then chikungunya IgM and parvovirus IgM, scrub typhus IgM and Wilfilix test and Lyme's disease IgM was sent. No surprise, scrub typhus IgM was positive, Wilfilix test, and also it was positive for OXK agglutination with significant titers. Patient was started on doxycycline before the test result came, and patient had significant improvement over 2 days. Fever subsided, joint pain decreased, CRP ESR found to be decreasing, and this was the test results. Doxy was given for 8 days after the test results in IPD, that of total 10 days, and discharged on doxycycline, antacids, NSAIDs, and with other supportive measures. Patient was given physiotherapy concurrently during the stay. On follow-up, patient was not having any joint pain, no more fever, myalgia, and he came after 3 weeks with ESR of 12 and CRP of 12, continuing to do his job without any problem, and other routine activities also. And our diagnosis was scrub typhus induced arthritis, and it's usually caused by Orantia shushugamushi. And Wilfilix test was the usual investigations are Wilfilix test we can do, indirect immunofluorescence, PCR from SR or blood we can find. Usual treatment is doxycycline, azithromycin also can be used. This was the patient came back, and on follow-up he can do all the routine activities. He can sit cross-legged, and he was very happy.
He was a bodybuilder, cut person. He was a Mr. Kottayam ayirunnu, and he belongs to that place only, and he is much better now, recovered very well. Why we presented this case is to say still what Hutchison says, history is very, very important in the clinical process or in the life of a physician. Nothing can replace a good clinical examination. So only the clinical finding which they brought out, that made us to think in favor of a scrub typhus, and SCAR we found, and the SCAR is the diagnostic sign, and finally we reached into a diagnosis of scrub typhus. And response is also excellent with the tetracycline. That is the advantage. Don't miss. Always, whenever there is a suspicion like this, you have to do a test for scrub typhus, and the drug of choice is tetracycline. So the treatment is over with a cost of 24 rupees. Doxycycline is a very cheap, only 90 paise per tablet. Okay, so that this is a case. Pettannu matte case.
Thank you.
Last case. What? Just for the information, we are getting lot of cases of scrub typhus nowadays during workup of patients with different presentations.
Good evening, everyone. Ode to a node. We have a 27-year-old female patient with no known comorbidities presented to a local hospital in Muvatupura with complaints of fever fever for 1 week associated with myalgia and headache. On examination, she had multiple enlarged cervical lymph nodes. On investigation, she was manto positive, but sputum AFB and culture were negative. And FNAC from the node showed granulomatous lymphadenitis, and the ESR was raised, and from there she was initiated on ATT for TB lymphadenitis. And she presented to our OPD after 1 week of ATT with no relief of symptoms and with complaints of rifampicin-induced itching, reddish discoloration of urine, loss of appetite and vomiting. Now, on examination, there was enlarged lymph nodes on both sides, multiple non-tender, discrete, mobile group of lymph nodes in axilla and neck. The largest being the supraclavicular lymph node of 3 by 3 centimeter. And some differentials of granulomatous lymphadenitis, non-infectious being sarcoidosis, berylliosis, and infectious group including suppurative, including tularemia, cat scratch disease, and fungal infection. Non-suppurative causes being TB lymphadenitis, atypical mycobacterial infection, toxoplasma, lepra, brucellosis, and fungal infection including cryptococcosis, histoplasma, and coccidioidomycosis. And from here, we reinvestigated the case, and FNAC was taken from the swelling in the left upper neck, and from where non-specific hyperplasia, left cervical lymph node was seen. And next, we did a biopsy, true cut biopsy by the surgery department was done, and from in which there was features of favoring reactive lymphadenitis with ill-defined granulomas. And the IHC markers were CD3 and CD20 positive, which were merely reactive pattern. And the tissue TrueNut was negative for MTB. And concurrently we did other investigations including Brucella IgM, scrub typhus IgM, sputum AFB, and ACA, which were all negative. And the diagnostic investigation being toxoplasma IgM, which was raised, Nobel being 8, it was 70 in this patient, and toxoplasma IgG being 8.8 for positive, being more than 400 in this patient. And acute toxoplasmosis in an immunocompetent individual can present as cervical lymph node enlargement, fever, malaise, retinochoroiditis, and in immunodeficient patient, it can come with seizure, altered sensorium, headache, encephalitis, meningitis, myocarditis, and pneumonitis. And for treatment, in an immunocompetent non-pregnant patient, it's a 6-week regimen of pyrimethamine plus sulfadiazine combination or 4-week regimen of trimethoprim sulfamethoxazole combination. And in pregnant patients being spiramycin. And in our patient, we had started on a 4-week regimen of cotrimoxazole, and she has resolution of the improvement in all in her condition, including all her lymph node enlargements were disappeared, and her condition improved dramatically. So that's all. Thank you, everyone.
Yes, this patient is also from my own native place. Our neighbor. And the interesting thing is that ഇത് വന്ന ശേഷം അവിടെ പട്ടികൾക്കൊക്കെ വിഷം വെച്ചു. 6 എണ്ണം പട്ടി ചത്തുപോയി. ചത്തു കഴിഞ്ഞപ്പോൾ എന്ത് ചെയ്യുന്നു വെച്ചാൽ എന്താ കാരണം എന്ന് അന്വേഷിച്ച് കഴിഞ്ഞപ്പോൾ ഇയാൾ 2 വെറ്റിനറിക്കാർ വന്ന് എൻക്വയറി നടത്താൻ പഞ്ചായത്ത് ഓർഡർ ഇട്ടു. അവർ നോക്കിക്കഴിഞ്ഞപ്പോൾ അവിടെ ഉണ്ടായിരുന്ന 4 പൂച്ചയ്ക്കും 3 പട്ടികൾക്കും ഈ ടോക്സോപ്ലാസ്മ ഡിസീസ് ഉണ്ടായിരുന്നു. അപ്പോൾ അതുകൊണ്ട് ടോക്സോപ്ലാസ്മോസിസ് ഈസ് ഓൾസോ നോട്ട് എ very rare condition in our place. Usually we are getting patients, അല്ലെങ്കിൽ ഇൻവെസ്റ്റിഗേറ്റ് ചെയ്യുന്നത് ഗൈനക്കോളജിക്കാർ മാത്രമേ ഉള്ളൂ. അവർ ഈ റിക്കറൻ്റ് അബോർഷൻസ് വരുമ്പോൾ അവർ ടോക്സോപ്ലാസ്മ ചെയ്യും, ടോക്സോപ്ലാസ്മ ചെയ്യും, എന്നിട്ട് പോസിറ്റീവായിട്ട് അവർ നമുക്ക് റെഫർ ചെയ്യും. ആ പേഷ്യൻസിൻ്റെ ഡ്രഗ് ഓഫ് ചോയ്സ് ഈസ് പൈറാമൈസിൻ അല്ലെങ്കിൽ റോവാമൈസിൻ. അതാണ് എൻ്റെ ഡ്രഗ് ഓഫ് ചോയ്സ്. ഡോണ്ട് ഗീവ് സൾഫർ റിലേറ്റഡ് ഡ്രഗ്സ് ഓർ എസ്പെഷ്യലി പൈറിമെത്തമിൻ ഷുഡ് നോട്ട് ബി ഗിവൺ ടു pregnant ladies. So that is the message today. And our message is all that glitters are not tuberculosis. all glands are not tuberculous. All patients who are having lymph node biopsy showing granulomatous lymphadenitis. If caseating granulomatous lymphadenitis, we are permitted to start ATT. Sani sir is very well versed with the tuberculosis management. And if otherwise, we have to investigate the patient in detail for the other causes. Last time, one more case was there with we diagnosed it as toxoplasmosis. After 2 years, again the gland recurs, and during biopsy it turned out to be lymphoma. So all patients with the cervical lymph node enlargement is to be followed up for a minimum period of 5 years for recurrence, including tuberculosis. Here we have done immunohistochemistry to rule out lymphoma, but still there is a possibility. This possibility we have to keep it in our mind, and we have to investigate the patient. So this patient has got a very good and wonderful recovery. All lymph nodes. This recently, last week, we did an ultrasound also, and all lymph nodes regressed very well. Thank you. Thank you for the patient listening.
Today, a patient with fever, with all sorts of detailed investigation, most tests came out negative. Now that we are primed towards toxoplasmosis, today one of our patient test result came out to be positive for toxoplasmosis. And mind you, almost in the past 2 or 3 months, we had almost 6 cases of toxoplasma, and all these patients are immunocompetent. Just like the question sir asked regarding the fungal meningitis. These are all immunocompetent people. In contrast to the conventional teaching that toxoplasma happens only in HIV or immunocompromised people, these are all immunocompetent. There's no evidence. We did the other tests like HIV, look for any other reason for any paraneoplastic, any hidden malignancy, all returned negative. These are immunocompetent people. So our now working plan is, if the straightforward test panels like cultures are all negative for any obvious cause, our next second line panel for all these atypical fevers would include scrub, toxo, Lyme, brucella. We had one case of a young chap, intermittent fever for almost 1 month, went to multiple places, no resolution. Then fever became continuous, came to us. Again, this patient had multiple cervical lymphadenopathy. Again, with the straightforward thing, okay, could be TB. FNAC, again inconclusive. The same report, non-specific granulomatous lesion. But specifically went to the histopath, no caseation. Should we do a biopsy? But in the meantime, since we were primed towards toxo, the test result came out to be positive for toxo, stop the test result, initiate treatment for toxo. So the patient who had 1 month fever disappeared in the next 2-3 days. We came for follow-up, no recurrence of fever, completed treatment, and he's off. Thank you.
I thank all the students for the wonderful worked up cases, and I thank Dr. Jilse and Dr. Abhilish for the moderating case. I request Dr. Augustine to come forward to give a memento to the students. Dr. Sanal Babu, please come. Dr. Jasmine. Dr. Dayana Jose. Dr.Akshara. Dr.Thasmi. One more. I request Dr. Abraham Tira to come forward to give a moment to Dr. Jilse. Dr. Abhilish Chacko. Now I request Dr. Somesh for organizing matters.
Good evening, everybody. We had an executive committee meeting on the 11th of this month. So, as we had mentioned before in the previous meeting, we'll be launching an official APA WhatsApp group shortly. We have some hiccups in it, but we'll be launching it by this month. The group will have exclusive association matters and information that will be passed on to members. There will be no forwarding messages. Mostly this group will have dates on APA meetings, other cultural activities that's being organized by the API. The other group can be used for forwarding various messages. Now API Coach is also planning to have an outstation family get together. Now the executive committee has evolved a few destinations with certain suggestion. A wholehearted cooperation from all members is solicited for making this outstation meet a success. Suggestions were mainly confined to two categories. It can be a local or national destination. It will be for a period of 3 to 4 days. International destinations are also being contemplated. Mostly will be in the month of September, October. Now coming to today's meet. We had a wonderful brainstorming session as you all had enjoyed the discussions. On behalf of the organizing team, we would like to express our gratitude to our scientific chairman, Professor Jilse George, for moderating this excellent case presentations. Thank you, sir. I'm sure all the audience were engrossed in the case discussions, and most of us had learned the various inputs and messages. I express my heartfelt thanks to Dr. Abhilish Chacko, who played an important role in organizing today's case discussions from Lisie. Thank you for moderating such wonderful cases. Dear young doctors, Dr. Thasmi, Dr. Akshara, Dr. Dayana, Dr. Sanal Baby, and Dr. Jasmine. It was wonderful to have such young doctors to come forward and present cases in front of such an august audience. We know it was very busy, you had very busy schedules in the hospital. In spite of that, you took great pains for presenting such cases. Most of us, including the consultants and postgraduates, have immensely benefited from your case discussions. Thank you. Thanks to Arun Moses and Solomon for a glitch-free CME. And most of these sessions will be recorded and be posted in the official API group after a period of 2 to 3 weeks. Thanks to Nila for arranging a wonderful feast that's coming afterwards. We appreciate the efforts of Jiju and Vibin and the IMA team in helping to organize today's CME. Most importantly, we thank every one of you respected delegates for having accepted our invitation and encouraging us by your presence. Thank you all once again and have a good night. I hand over the session to our chairman.